Great stuff. So we are going to start with today's session, and then, yeah, let's engage. Please do share your comments through the chat, and then hopefully we are able to respond. So again, just to declare that this presentation is based on my own experience in the clinical space, but also all the local guidelines that we use for the management of both HIV and TB. At the end of this session, really, the aim is to outline the assessment, investigation, and management of patients who are co-infected with both HIV and TB. And we would regard patients who have these two infections at the same time to be having, complex HIV disease, or what we call advanced HIV disease, needing really, to be cared for very carefully. I just added this slide, to kind of like start to show the relationship between HIV, and TB. And you would see that in regions where there is the low prevalence of HIV, you'll also find that the incidence, of TB is significantly low. In regions like the sub-Saharan region, which is where, we live, South Africa, Zimbabwe, Swaziland, these are regions that have a very high prevalence of HIV, and you would see that equally, these regions would have huge numbers of TB cases, on an annual basis, showing that relationship that HIV seems to fuel, the occurrence and the spread of TB cases in the country. Therefore, it's quite important that when you are working in the TB space, you are also well capacitated to deal with HIV. And those of you who are working in HIV clinics, that you are also very competent in the management of TB, because the co-infection rate of these two diseases, in certain settings, you'll get that up to 76%. It means for every 10 patients who test positive, around 7 of them are likely to have TB. But to set the tone for today's session, we will go straight into a case, a very basic scenario, but we will build on it as we look at the interface between these two infections. So here we have a Mr. Vuyo, who presents to you with a cough and night sweats, which started anyway, this is last year. And then there's a history that he worked at the mines and he has had TB before. Now, when you see a patient, a client like Mr. Vuyo presenting like that for the first time, what are some of the assessments that you might want to do? So I know you have a lot. You can even type in the chat box, but I'm sharing a question with you, which you should be seeing on your screen there. I would like you to select, you can select more than one answer. What are some of the assessments that you might do when you are presented with a patient who has cough and night sweats with a history of TB? So I'll give you 5 more seconds, and then after that, I will then just show you how it goes. All right. So we give our polls, these questions, 30 seconds. So if you have not voted, it's okay. We'll try with the next one. So I'll just show you the results that most of you said physical. Yes, so you need to take further history to understand, these symptoms, associated symptoms, quite important. We need to assess disease severity, because we need to determine whether Mr. Vuyo is someone whom we can manage on an outpatient basis or they need to be admitted. HIV testing, very, very important. Collecting sputum for gene expert, yes, but collecting sputum for a TB smear, not at this point in time, right? Because in our algorithm, which I would show you, our key diagnostic test for TB is a TB gene expert, and we only do a smear once we get a positive gene expert. So the first 4 options would be some of the things that we need to do, except the final option there on TB smears, which we would need to pack, for now. So here's further history, about our scenario. It's not yet drug-resistant TB, but it's a build-up. So on further inquiry, you determine that he is 45 years old and he complains of a productive cough, which he has had for 4 weeks with fever. He does not have any shortness of breath. or any rashes at this time. He tells you he is HIV positive and his CD4 count is 120 cells. You examine him, you determine that he's got a high temperature, the blood pressure seems normal, the pulse is normal, respiratory rate just, there, 24. He appears thin but not emaciated. He is calm, comfortable. His chest exam reveals upper lobe crackles. Otherwise, everything else is normal. Now, based on what you are looking at here, do you think that Mr. Vuyo here requires urgent care or not? Is it someone who needs urgent care, or it's someone who can be treated on an outpatient basis based on how he's presenting today? Does he need urgent care? Okay, you've got 10 more seconds, so try to participate. Then I will show you, then we can look at the framework we can use to make these decisions. All right. All right, I'm going to stop there and then show you the results, and you would see that it's a tie in a way. Some of you say yes. I wonder what is it that you saw, which says that he needs urgent care, but that the majority, 55%, are saying no, he does not need urgent care. So maybe let's look into this particular question. So in pneumonia, remember he's presenting with, sometimes we forget that TB is also a community-acquired pneumonia. So there's what we call the community-acquired pneumonia severity assessment. It's called the CAP 65. And basically, if a patient presents with these 5 signs, you might then consider that the patient needs urgent, attention. For example, if Vuyo is confused, if we can confirm that he's got a high urea or in acute, renal failure, if he's got the respiratory rate of above 30 breaths, remember he has an RR of 24 breaths. If he's hypotensive, if I remember the blood pressure was normal, and also if it was an elderly patient, and I remember he's 45 years old. So based on your assessment of these particular points, you would then allocate a score of 1 for each of these. And if Vuyo would have a score above 3, we would regard him as high risk and needing urgent attention. If the score is 1 or less, he would be low risk. And if it's between 1 and that 3, which is a score of 2, we would say that he's got moderate risk. We need to be a bit careful with him. But I can tell you, based on this particular assessment, Vuyo is probably a low-risk patient whom we can try and manage on an outpatient basis. But please remember, in HIV, patients might not present, with high temperatures, even when they are very, very, very sick. So sometimes use your own clinical judgment to determine whether this patient would need urgent care or not. So if a patient presents like Vuyo, productive cough, he's got this, he's not dyspneic, but he's got productive cough, he's HIV positive, his temperature is 39, all the other vitals, they are just averagely, normal right there. What would you consider as a potential for your differential diagnosis? What are some of the things that you think we need to consider and try and exclude at this point in time? There's a question in front of you. You may select your options. You may even type so that we can have a nice discussion. Great, 5 more seconds. Then I'll show you your selections. Remember, we only put out these questions for 30 seconds, and I'm sorry about that. Sometimes they have so many options that you want to read them slowly. All right. So yeah, so let me show you the results, and then you'll see. So TB seems to come as tops, and then some bacterial infections, yes, tops, and then maybe COVID-19. And this is quite important. And I will ask Dr. Jeremy Nell to come and present the interface between HIV and COVID-19. And you would see that some patients who are suspected to be having COVID-19 in HIV, they might actually be having PCP. or even some serious bacterial infection. So it's quite important to always have a broad view around what could be going on, because sometimes we are so convinced that it's TB. We only do your gene expert, but we forget that these patients might be having, other infections as well. So I sort of agree, with what I see, but with PCP, he would probably be a bit more sick than he is, and PCP rarely presents with night sweats, so yeah. But the COVID-19, we should never say never. And in today's world, anyone who's coughing, we should consider whether it's COVID and then also PCP, especially because Mr. Vuyo has a very low CD4 count, below 200 cells. And from the history, we don't get an idea that he's taking cotrimoxazole. So the same score can be used, to investigate your differential diagnosis. So like for him, his CAP score was 1, isn't it? We said low risk. So probably we can just get away with starting him on oral antibiotics and investigating him for TB. But if he was very sick, coming in with a CAP score of 3 or more, we then want to do further studies like your sputum. You still check for TB, but you want to do a gram stain to check for bacteria that might grow. You want to assess for PCP. You want to assess for some uncommon, infections, including some PCR tests for flu, but also, in today's world, COVID-19 as well. If he has a history of recently being admitted, you might want to do blood cultures to exclude some of the hospital-acquired pneumonias. So you would see that in this approach, I'm trying to say to you, yes, we know that 90% of the time TB is the problem, but you also need to consider other common things, and sometimes TB can be present with other infections, and that's why our patients sometimes can deteriorate a bit faster, right? So in terms of symptoms, and you must remember, in terms of sensitive TB versus drug-resistant TB, you cannot differentiate these two types of TB based on how your patient presents clinically. Usually it's from a suspicion, if they were previously treated, if they are on treatment and not doing well. But in terms of how they present, it's still the same: cough, fever, night sweats, unexplained weight loss. If they have extrapulmonary TB, they might present with a swollen joint. They might present with, a huge lymph node somewhere, a swollen abdomen. But in terms of constitutional symptoms, unintended weight loss, night sweats, and fever tend to be common. But generally, the symptoms as associated with a specific organ that is involved sort of give you an idea of what might be going on. And remember, patients can get extrapulmonary TB, whether from sensitive or from sensitive or resistant TB. So like I'm saying, you cannot differentiate between these two TBs based on how your patient presents clinically, right? That's why DRTB has more to do with the lab. This particular slide is very crucial, right? Because you should always note that particularly in late HIV infection, it is quite, difficult to diagnose TB because, one, when you assess HIV positive patients who have significant immune suppression, the clinical picture that you read in the textbooks around night sweats and productive cough, those kind of things you might not have, especially because they tend to have extrapulmonary TB. So you have to do a full examination and assess your patient comprehensively. And also, if you do a traditional sputum smear, you'll see that they are often negative in advanced HIV disease. And this should tell you that a negative a TB smear, a negative gene expert in an HIV positive patient does not exclude TB, right? Because these patients with severe immunosuppression tend to have a negative sputum result even when they do have TB. So you have to make an effort to look deeper to find this TB. X-rays as well, they are more useful in patients who are still immune competent or HIV negative patients, because if you see cavities in the upper lobes, you kind of like think this is an aerophilic infection, it likes, fresh air, then this is probably TB. But remember, to get cavities, you need an immune response. So your HIV positive patients with advanced immunosuppression might not have symptoms. Smears might be negative. The X-ray can also be normal, even when TB is actually there. So these diagnostic tests might not exclude TB, but if positive, they are quite useful. But if they are negative, you therefore have to look deeper. And I put a nice, very simple, table to show you some of the common diagnostic tests that we use to diagnose TB. And you'll say, but he said the topic is drug-resistant TB, and now we are discussing normal TB or sensitive TB. Remember the entry point to DRTB and the timeliness of diagnosis and the timeliness of starting treatment has to do with how we manage sensitive TB in the first place, right? And actually, it is the failures of managing sensitive TB that are contributing to significant cases of drug-resistant TB. But the message here is clear that you have a microscopy, which is a smear where the results usually come back and say AFB present, 1+, 2+, 3+. You'll see that its weakness, it's got a low sensitivity in people with low bacillary load, particularly children and people living with HIV and AIDS. So a negative smear does not exclude TB in HIV positive patients, right? Culture is the gold standard. The only problem is the turnaround times, because for you to get the result, you need to wait at least 3 to 6 weeks, and sometimes even longer than that. And some of these patients might be very sick and not, survive that long. In today's world, we use molecular tests, your line probe assay, which I'll talk more about shortly, but and your gene expert as well. But pay attention to the weaknesses of this test, right? Reduced sensitivity in patients who have a negative smear, right? Which patients are those? Children and people living with HIV and AIDS. The same applies to the gene expert. It's got a reduced sense, it's got its ability to detect and to diagnose TB is significantly reduced in the context of HIV. So these tests, actually most, if not all, TB diagnostic tests, they are useful in HIV when the result is positive, right? If the result is negative, you cannot exclude TB by relying on the diagnostic test. You also now have to consider your clinical judgment. Your patient has symptoms, they have not responded to antibiotics, everything smells like TB, it's probably TB, even when the tests are saying negative, and you should probably treat for TB in our context. So that is quite, important as well. So I'm continuing from there. So here's Vuyo, in the first scenario, the TB expert results are back and they are negative. So you've got an HIV positive patient who's got symptoms suggestive of TB, and his sputum results come back negative there. So what is your approach at this point in time? How do you manage HIV positive patients who have a negative TB expert? What the options? Some of the options, if they're different, you can type in the chat box. I'm able to see them, but you can also try what you see there. Nice. I like your options. Let's all participate so that the graphs can be representative of us and what we do. All right, 2 more seconds. Yes, I'm going to stop. And then I want to show you. So yes, I really like this. So I think, the first point there is the one which I was talking about. A negative gene expert does not exclude TB in an HIV positive patient. So you want to look further. You collect a sputum for DST and culture. You start your patient on antibiotics, because if they respond on antibiotics, it's probably not TB. But if they are not becoming better on antibiotics, you are thinking this can still, be TB. Then you review, assess based on clinical progress. So the last three, very important. And then your ARVs, yes, he needs ARVs, but not now, right? Because we still have to decide. He's still symptomatic, so we want to deal with these symptoms and ensure that there's no TB before we can start ARVs. So I'm quite happy with how you have approached that. And what we are talking about is this part of the algorithm where you have a TB suspect, you have collected sputum for gene expert, the expert comes back negative. You have to assess HIV status. In our case, is an HIV positive patient with a negative gene expert. So the advice is that you need to try and find TB. Check again your symptoms, collect another sputum for culture and DST, treat your patient with antibiotics and review after 5 days. Do an X-ray if it's available, but remember, you could still get a normal X-ray in the context of TB in an HIV positive patient, and that is quite key. There's also a point of care test. We call it a urine LAM, which you can do for any sick HIV positive patients or any HIV positive patient who's got a CD4 count less than 200. So it's also a test that you can do to try and find this TB. Then based on whether there is progress or not, then you decide, if the patient is not improving on antibiotics, the symptoms are still there, they probably have TB, right? It's a question of, are you going to wait for the culture results or not? And that depends on how badly you are, how sick is your case. If they are very sick, you start TB treatment. You'll review, later on. But if they are still stable, you might wait for your culture results, and then you take things from there. So I hope, this is quite helpful for you. Now, in a second scenario, it's the same VUYO, but the TB expert this time is positive, and the RIF sensitivity is also, so he does not have a RIF resistant. So it's a TB, it's a RIF sensitive TB diagnosis. In terms of this kind of a patient, would your management be different, where the rifampicin is positive and it's also sensitive to rifampicin? Your TB expert is positive and sensitive to rifampicin. What would be your options right there? All right. Let's go for it so that I can show you the results in 10 seconds time. Thank you for participating. I enjoy your participation. Please do type also in the chat box and the Q&A, as we go through these slides, and let me know how it's going right there. I'm going to stop now and I'm going to show you. And really, yes, the biggest change is that in this context, we should be starting, TB treatments or RIFA4. And that is the first time now you're going to do a TB smear. So TB smears are done once your gene expert is positive. There's no need for a culture at this time, unless if the previous TB is very recent and maybe it was drug-resistant TB. So if there's further history around that, you might want to do a culture. ARVs probably in 2 weeks' time, right? Once we have started TB treatment in 2 weeks' time, we may consider ARVs. So in terms of the algorithm, we are on your far left there. So gene expert positive, rifampicin sensitive, we treat as TB. When we say regimen 1, we mean RIFA4, rifampicin, isoniazid, ethambutol, and pyrazinamide. Then you collect one specimen for microscopy, because remember the golden rule. We always diagnose TB with a gene expert, but we monitor treatment progress with a microscopy. That result that tells us that the AFBs, are they present or not? And is it 1+, 2+, or 3+? That's why a gene expert, once positive, should never be repeated to monitor treatment progress, because it would remain positive for at least 2 years from the time when TB was diagnosed, right? Because it is a DNA test. It will always pick up DNA, whether from a live TB bug or from a dead TB bug. So we don't repeat gene experts once we have diagnosed patients, but we collect a microscopy, and if it's 3+ at the end of the treatment, we expect it to be negative. You know, a negative smear is what we want to appreciate. And remember, once you have diagnosed TB, there's also further assessments that we need to do, you know, microscopy or BMI, blood glucose, because there's quite now a strong relationship between diabetes and people who are getting, you know, TB. HIV testing is important, pregnancy, screening for substance abuse or use, you know, a chest X-ray, you know, just baseline to know what's going on in the lung. So once the diagnosis is made, we now also need to do a baseline evaluation for our patient right there. The treatment for TB has not changed, it's still the same, RIFA-4, you know, except that if you have a child who's less than 8 years or less than 30 kgs, and they have uncomplicated TB, just simple pulmonary TB, you can actually treat them with 3 drugs, right? You exclude ethambutol because of the risk of optic neuritis, color blindness, and eventually blindness. But if the child has complicated TB like TB meningitis, TB of the spine, the benefits of treating that child with 4 drugs outweighs the risk of any eye, you know, issues that the child might experience. So just remember, with children, we can still treat with 3 drugs as long as they have simple pulmonary TB. So in terms of sensitive TB, it's got the intensive phase and the continuation phase. The intensive phase is lasts for 2 months using 4 drugs. And then once the smears come back negative, we then take our patient through the continuation phase, and then hopefully they complete, and then, you know, things go well, you know. So just a reminder, really, before we get into some serious things right there. So now here's scenario 3. Vuyo is back as the TB expert result. They come back and the result is positive, and the rifampicin now is resistant. So he's got the rifampicin resistant TB. What would be your management approach? What does the guidelines say? How do you manage a patient who's got a positive TB expert result and is rifampicin resistant? Right. Yes, let's participate. I know now we are talking, you know, we are getting to the complicated things, but yeah, we will learn together. Dr. Mudiba, my colleague, are you there? I don't know if he's back. Dr. Mudiba, are you there? Okay, he will let me know when he's in a safe space. Okay, I'm going to stop and then share with you.
Dr.
Yes, are you in a safe environment?
Yeah, no, I'm safe. I've been I've arrived 15 minutes ago, but yeah, I've listened. Yeah, so I'm settled. So yeah, so far so good.
Yes, can you outline for us what should happen once we have a TB expert result that is positive and the rifampicin is resistant?
All right. So I think I'm looking also on the poll, and then I could see that most of the people are referring to their TB clinic, meaning they've realized this is not a drug-sensitive TB, and it's a drug-resistant TB. So, which is very, very important to realize compared to what you've just highlighted in terms of the sensitivity. So we need to, as healthcare professionals, we need to distinguish between the drug-sensitive TB and drug-resistant TB. So the moment now you see gene expert coming with a resistant to rifampicin, it's important to know that now we are dealing with a drug-resistant TB. And it's very important to make an assessment for that patient, which encompasses a lot of things like taking some sputum and assessing the patient, taking chest X-rays, because that will also tell you if the patient will take any regimen of some sort. You have just highlighted on the poll in terms of the start of short regimen and a long regimen. That also could be determined by the assessment based on the patient. It's not directly linked to the gene expert per se. You still need to make your assessment of the patient.
Great. Thank you very much for that, Dr. Mudiwa. So yes, one, discussing, because now the referral issue is also being minimized because the management of drug-resistant TB is being decentralized, and I think Dr. Mudiwa will tell us more about it later on, to allow district hospitals, for example, to manage these patients. So yes, referring and discussing with an expert or someone experienced in DRTB is always a good idea. A reflex DST, which we will discuss now, and then deciding, whether you're going to give the short standard best regimen or your patient has to take the longest regimen. So those are some of the decisions you are going to discuss. And you must remember, he worked at the mines and has had TB before. And this kind of a history sentence from history, we need to get more information, because if this TB he had before, just for argument's sake, was a MDR or something like that, or he was exposed to second-line drugs before, he's probably not eligible for the short regimen. But I will take you through some of those theories shortly. So once your expert is positive and the rifampicin is resistant, the patient has to be treated as MDR. You refer, or if you are working in the decentralized facilities, you then initiate your patient on drug second line anti-TB drugs, right? And then you'll also further collect. Now, this is different. Remember, for sensitive TB, once we had the diagnosis, we only collected a sputum for microscopy. But for all your DRTB patients, you need to collect a further specimen for culture DST, right? And this is DST now for some of the first-line drugs, rifampicin and isoniazid, but also for some of your second-line drugs, your fluoroquinolones and your injectables, your amino glycosides right there. And they would also do a smear just to make sure that we can know how bad is this infection. And then it's important to follow on these results, because these results can determine whether a short regimen should be continued or it needs to be changed to a long regimen, and if there's other changes that need to happen for this particular patient. So for the rest of the presentation, we are now going to deal with patients who have TB that is resistant to rifampicin and how to approach it. And obviously, we are going to start to look at why you need to collect this reflex test and what are they. So as soon as a patient is diagnosed to be having drug-resistant TB by virtue of having a TB that is resistant to rifampicin, a DRTB reflex test has to be done. And the rationale, the theory behind it is that drug resistance cannot be, like I said when we started, you cannot tell whether a patient has sensitive TB or resistant TB by just based on how they present clinically. You have to diagnose it based on using your laboratory tests. And we now know that most patients who have rifampicin resistance, a good proportion of them might have further mutations, or further resistance, making the second line anti-TB drugs to be more weaker and weaker. So we should be able to then, look further so that we can triage the patient to give the patient the correct regimen. So immediately, once your gene expert is positive and the rifampicin is resistant, we have to collect another sputum for DRTB reflex. So it's a reflex. In other words, you are collecting this sputum, but the lab is going to do a series of tests depending on the profile of mutations that are picked up when an LPA is done. So once you request a DRTB reflex, the lab will do a smear. Remember, for the AFBs, the 1+, the 2+, they will do a culture to grow the TB. They will do this molecular DNA test, LPA, assessing for both your first line drugs, rifampicin and INH, and then your second line drugs, which is your fluoroquinolones and your injectables, right? And further, based on the results of the LPA, they would further then look at the phenotypic DST now on the TB that's growing to confirm the results of the LPA, because sometimes you do get discordant results, and the LPA can miss certain mutations. So therefore, we need to also look at the phenotypic, not just the genotypic, or in other words, not just the molecular test, but looking at the old way of doing the culture, which is the phenotypic DST. So on your lab form, you'll see there I've circled it in red, DRTB reflex, testing. You're not going to request all these tests. All you need to do is to tick once there, DR reflex testing, and the lab will then do all these particular tests. And it's an algorithm. So basically, for most of the time, as clinicians, we stop here and refer, So once there is RIF-resistant TB on GeneXpert, we refer, But what usually happens that once you have RIF-resistant on TB, we have to collect a second, sputum for what we call DRTB reflex, which is a series, of tests which include microscopy culture, DST, drug sensitivity testing for both first line and second line TB drugs. And you would see here that the first thing they do is an LPA, a line probe assay. It's a similar test to GeneXpert, except that line probe assay is also able to detect mutations against INH. Remember, GeneXpert only tells us that there is rifampicin resistance, right? Then you've got LPA, which will tell you whether you've got rifampicin resistance or not, and whether you have INH mutations as well. So for example, here, once your LPA, oh, sorry about that. I don't know what happened. Few seconds. Let me. Yes, something was disturbing me there. So like I was saying here, if your LPA results come back and say INH susceptible, right? So you are happy, there's no mutations, but now you are thinking LPA can miss certain mutations. So we have to do a further test by assessing INH resistance on a culture medium. This is what we call a phenotypic DST. So that is why we call it a reflex, because what will happen traditionally, you would get the result, then you order another sputum for the lab to do a culture, which was wasting time. So these are reflex tests. The lab will automatically be doing this test depending on your ALP results. You'll see here, both mutations against INH have been detected, INH-A and KG. Automatically, the lab will then do a phenotypic test, firstly to confirm these mutations, but also to look at if other second-line drugs have been affected, linezolid, bedaquiline, and clofazimine, right there, right? Again, if your LPA says there's sensitivity to fluoroquinolones, there are no mutations, yes, we are happy to see that on LPA, but we want to make sure, especially because your LPA will only tell you that's sensitive to fluoroquinolones or resistant to fluoroquinolones, but it doesn't tell you which ones. I'm sure you can see it there, because fluoroquinolones is a big group. There's levofloxacin, ofloxacin, moxifloxacin, so to determine further whether there might be some level of moxifloxacin resistance, you therefore need to do a phenotypic DST. So quite important. Once you get a rifampicin resistant TB, a sputum is collected for TB reflex, the lab will be doing all these reflex tests depending on the result of your line probe assay right there. So when you say line probe assay, it's similar as your genotype, but however, in terms of labor, I know that it has a very laborious process of extracting the DNA from the sputum, amplifying it, further hybridization and interpretation to detect mutations that this particular TB bug might be having at that point in time. The nice thing about LPA, it's able to detect both mutations against rifampicin and INH. So, it's a very good thing, and it's able to detect up to 95% of RIF resistance. So there's still the 5% that it might not detect, which is why we always need to confirm with a traditional culture, a phenotypic test, right? It's very important to note that in terms of INH resistance, it is also able to differentiate between these two key mutations, your INHA and your KG mutation, which confers high level resistance to INH. Very, very, very important in terms of, so it will tell you which ones the patient might be having, right? So also the LPA may detect cross resistance to fluoroquinolones, but remember, like I told you, it won't tell you which ones. It will only say fluoroquinolones are sensitive or fluoroquinolones are resistant, but the culture, when it comes back, it will be specific to say there are mutations against levofloxacin. And also you should note that most of the time LPA will miss mutations against moxifloxacin, right? It's generally strong to detect, mutations that are linked to the GYR gene, which is for ofloxacin and levofloxacin. So LPA, in essence, one, it is able to diagnose rifampicin and INH resistance. It is able to diagnose second-line resistance against your fluoroquinolones and your injectables, quite important. And actually, the WHO recommends that it should replace culture. Basically, it says LPA should replace culture, but capacity and technicalities are still there. So we still do cultures in our context right there. So in terms of drug sensitivity tests, you've got your genotypic and your phenotypic, right? So here you are growing the bug, and here you are relying on the molecular test. Now, your LPA can detect first line and second line resistance, right? So first line, it's rifampicin and INH, basically, right? Second line, it's rifampicin and INH, but in addition, it can detect your fluoroquinolones and your injectables, your amikacins, and so on, whether there is resistance to those type of drugs. Then you've got your culture growth, which can be used to confirm. Now you see now the language is to confirm, because you would have already received your LPA result. Now you are confirming your LPA result with a reflex culture, right? It can detect that. Your culture, in addition to just saying fluoroquinolones, it can be specific to say there's actually resistance to levofloxacin or to, so the specific drug right there. And then also your culture is used as well to detect sensitivity or resistance against your other second line drugs, linezolid, bedaquiline, and clofazimine, right? Which, I mean, these are words you will learn the drugs. I had to learn them as well, And then sometimes when patients have very complex resistance profiles, so there's resistance to rifampicin, there's resistance to your fluoroquinolone, and some resistance to bedaquiline, and you need now an individualized extended phenotypic DST, you then call NICD. It's not on the form. This one you must talk to a microbiologist and say, hey, I have a very complex case. Can you do an extend and assess all the other drugs to see which drugs we can actually use for our patient right there. All right, you guys are very quiet. Are you still with me? I know it's in the afternoon on a Thursday. Can you just type there and tell me, reassure me, please, that you are still with me as we discuss this complex topic. Okay, thanks, Lebohang, Leta. All right, Zikona, superb. Shezi there, Dr. Mwimba. Yeah, great stuff. Okay, great stuff. I'm so happy that you are still following, because sometimes DRTB in an hour can be a very complex topic, right? So let's say you have done the LPA, let's say you have done your LPA and you have your result, and the result says RIF sensitive. So now remember, now LPA is done after a gene expert. In other words, you did a gene expert, right? Which was resistant. That's why you are doing an LPA. Then the LPA results come back and say sensitive. So these are discordant results. You don't stop drug-resistant TB. You continue treatment and you discuss with the lab. You say, hey, the gene expert said resistant, but now your LPA says sensitive. What must I do, right? If the LPA result comes back and says RIF resistant, it is confirming your gene expert result. You continue your regimen, and you might want to include high dose INH or modify as per further, mutations that are picked up. If the mutations against INH, your INHA and KG mutations are documented individually, you don't need to change the regimen, right? You just continue. It's just a decision to say if there's KG, because KG is a high level mutation against INH, you need then to increase your dose of INH to give the highest possible doses for KG right there. However, if your patient has both INHA and KG mutations, remember these patients are not eligible for a short regimen. They will always get a long regimen for your drug-resistant TB because they've got both INH mutations in the same TB right there. If it says sensitive to INH, we are happy, but all sensitive INHs must be confirmed with a phenotypic test. Remember, LPA can miss some of the mutations. That is quite important. If the LPA says, now in terms of your second line, it says no, fluoroquinolones are safe, everything is okay, you continue your regimen for 2 months with linezolid, and then you do a phenotypic DST to confirm whether levofloxacin is still okay. So remember, it's confirmation with phenotypic culture, right? However, if it says resistant to fluoroquinolones, your patient is not eligible for a short regimen and they need an individualized TB regimen to make sure that they get the best regimen that they can. And I've put an example for you. I put down an example for you. You can see here, this is a TB reflex, right? They did the smear, which is 1+ positive. Now we're looking at LPA. This is not gene expert. Gene expert is already done. We know that it's resistant, but the LPA now says INH is sensitive, rifampicin is resistant. So it's confirming your gene expert results, right? But remember, when you do LPA, you do for first line, you also do it for second line agents. So for second line, fluoroquinolones, you see now there's a problem. Mutations were detected. So this patient cannot get just a standard short regimen. He needs an individualized regimen because there are some mutations against fluoroquinolones. But can you tell which fluoroquinolones? We can't tell because this is an LPA result. So if you want to know which ones, you then need to check and wait for the results for your phenotypic or what you call a culture result right there. So you can see now, this is now MGIT culture, isoniazid is resistant. You see now, if you remember, LPA had said INH sensitive, and I said LPA can miss mutations. So don't forget to check your culture results. And then they also check for your clofazimine, bedaquiline, and linezolid, and you can see there's some resistance to also those second line drugs. So this type of a patient is in trouble, isn't it? He needs a very individualized regimen. You must discuss with the microbiologist. They must look further. At least linezolid can still be used by God's grace right there, right? So yes, I hope you are still with me and you are following. So basically, once you have diagnosed rifampicin resistant TB from the lab, right, you must send a sample for DRTB reflex. Any patient who has a previous history of being treated with second line TB drugs for more than a month, right, or has complicated TB meningitis, TB of the spine, or has had a contact, so they have TB now, but they are staying with someone who's got XDR, they are younger than 6 years, they have extensive disease on the chest, so it's a very bad infection, or they've got both INH mutations, INHA and KG. These groups of patients are not eligible for the short regimen. They should always get an individualized long course regimen, which is usually having bedaquiline, levofloxacin, linezolid, trazodone, and clofazimine, and even additional drugs depending on the profile of these drugs. Remember, the long regimen is treated at a minimum 18 months, but it can go up to 24 months depending on how things are going. But you would see that generally it does not include the injectables, which is still a good thing, right? Then if you have a patient who's diagnosed with a resistant TB, but they are stable, no complications, they've never been on TB treatment, they are older than 6 years, these are the patients who can be considered for a standard short regimen. Just check the HB, because this drug, linezolid, you know, these drugs, you don't know whether it's linezolid or linezolid, they always correct me, is known to cause anemia, LZD there, right? So if there is anemia, then they might not be eligible for a short regimen. So a short regimen is for, you give it to stable patients who do not have any other issues. And once they are on a short regimen, do review your culture results, because if they come back with some resistant profile, you might need to change them to a long regimen. So this is the short regimen. The intensive phase, under normal circumstances, it should be 4 months. After 4 months, you do your continuation for 5 months. So usually with the short regimen, we mean this regimen is a 9 months regimen, right? I mean, really, if you know about DRTB and the injections and the type of side effects patients used to get, you would really appreciate moving away from 24 months to 9 months is a significant jump. Usually, the short regimen has a linezolid for 2 months, right? If everything goes well at 2 months, you stop it right there. And as long as a patient is on linezolid, we must always check their HBs every month. Very important. High dose INH for 4 months, bedaquiline for up to 6 months, and then your continuation phase will be levofloxacin, clofazimine, pyrazinamide, and ethambutol, right? You'll continue these for the whole 9 months. In the intensive phase, you'll give all the 7 drugs that you are looking at right there. So when we say shorter regimen, it's a daily administration of all these 7 drugs except bedaquiline. It is usually, bedaquiline is given daily for the first 2 weeks, then every 3 days in a week, like Monday, Wednesday, Friday, kind of a dosage. After that, monthly sputums for smear and culture, because that we want to monitor our patients very closely. The 4-month smear, so if you go back to this chart, the 4-month smear, so the smear and culture you are going to take there at 4 months is the one that's going to determine the duration, because if your patient has not yet converted, you don't start the continuation phase. They'll only start the continuation phase once they have converted from a positive smear to a negative smear, right? So if a patient has a positive 4-month culture, you know, then we might need to extend treatment or even consider them to have failed, and they might need to be reviewed and probably be switched even to an extended long regimen, so which is quite important right there. The long regimens in terms of principles, so anyone who does not qualify for a short regimen, usually it's patients who have very bad disease, extrapulmonary TB, you know, previous history of being exposed to second-line TB drugs, those patients need longer regimens. And like I said, the treatment is 18 to 2 years, depending on how quickly the cultures are going to convert. And the treatment is generally individualized to a specific patient with a specific profile in terms of their resistance results. As well, your longer regimens, WHO has grouped these drugs, you can see, into group A, B, and C, and they give you guidance to say, whenever you have a patient who needs a long regimen, all the group A drugs must be given as much as possible. You know, it's possible that sometimes, you know, one of these drugs you can't use, maybe the HB is 2, therefore linezolid is not the best drug. But you'll see that if it was a meningitis, TB meningitis, linezolid is very good because it penetrates, the CNS there. So those are the balances you'll be making. But your group A drugs are very important. Your fluoroquinolones, levofloxacin or moxifloxacin, plus bedaquiline and linezolid, always in the regimen. Group B, add at least one or both, depending on which one, terasidone and clofazimine. If you can add both of them, it's a plus because you already have 5 drugs. Then from these ones, you'll be needing just 2, drugs to add, and that is the principle. So with group C, you add the ones that based on the DST and the side effect profile that your patient has. But group A and B, you try to add all of them. Group A, they are very essential. Actually, if you have to interrupt group A drugs, you're going to need to treat your patient longer than you should have. So I won't go through this. This is now the summaries to say, short regimen, linezolid for 2 months, bedaquiline for 6 months, the other drugs, high dose INH for 6 months, and then the other drugs are continued up to 9 months and so on. There's a nice table as well there. So you remember we share the slides. Immediately after today, you'll get the slides. So please do review all the slides. You can see this is now the long regimen confirming that bedaquiline, linezolid, levofloxacin, clofazimine, terasidone will be taken for at least 6 months. The continuation phase is 12 months, so a minimum of 18 months. So really, we don't like this long regimen, but the short regimen is not for everyone, because otherwise half your patients would be failing treatment because the short regimen won't be adequate to treat them. So these are nice summaries which you will get with the slides for reference, very easy to refer. Let's come back to Vuyo. And just to remind you, Vuyo came in with cough and night sweats. The cough is productive. He's HIV positive. He's got a CD4 count of 120. His vitals are okay. The temperature was up. And then the expert was positive, RIF resistant. Now we have the results. Now I want to see if you were following. Eh? So here's the first and second line LPA results, right? We've got only one INH mutation, the INHA mutation, the sensitivity to fluoroquinolones and injectables, and all the second line. So everything is okay, except that we've got one mutation, the low, what you call your low risk mutation, your INHA mutation. Now let me see. Based on the profile that I've just shared with you there, what is the appropriate regimen for Vuyo? What is the appropriate regimen for Vuyo? I wish I could ask you. You must raise your hands if you want to comment. I wish I could ask you why you are saying long or short. It would be nice to hear your voices. But if anyone wants to try to make a comment, please do raise your hand. I'll give you the mic. It would be nice to hear from one of you. 2 more minutes. Are you 2 more seconds? Okay, that's fine. Let me show you the results. It's interesting, right? I mean, the obvious answer is a short regimen, because remember, if the patient has INHA mutation alone, a short regimen can still be used, or KG mutation alone, short regimen. But if the patient has both INHA and KG mutations at the same time, he needs a longer individualized regimen. If there was a resistance to fluoroquinolones or injectables or some of the second line drugs, we would be showcased that the patient needs a long regimen. So the simple answer for Vuyo is short, but please don't forget that Vuyo worked in a mine and Vuyo was previously having TB. So we must take history on that TB. What TB was this? And then this TB was treated with what? If he was exposed to second line drugs, he is not eligible for a short regimen. If his X-ray comes, there's cavities, the lung is destroyed with fibrosis, no short regimen. If he's got extra pulmonary TB, no short regimen, right? If he's got a TB contact where he got the TB from, and this TB contact is taking second line or XDR treatment, probably no short regimen. Vuyo needs a long regimen. But the simple answer for this question is a short regimen just based on the results. But don't forget, the decision for long or short regimen is mostly determined by the history and the clinical assessment of your patient. So that is quite important. So in the guidelines, which I will share with the slides, you'll find this table showing you all sorts of assessments that must be done, counseling, every month these patients must be assessed by a clinician. I'll just highlight a few things which are quite important, like, your pregnancy test. Okay, he's a male, maybe that's not relevant. Yes, remember, if we're giving linezolid, which can cause significant anemia, it's quite important that you do your HB baseline, then 2 weeks after starting linezolid, then 4 weeks after starting linezolid, and then monthly for as long as they are on linezolid right there. Then there's the issue of the eyes, which linezolid plus also ethambutol, they can affect visual acuity, color blindness, or even blindness. So you must always check the eyes. And then remember that the bedaquiline is also associated with prolongation of your QT intervals on your ECG, sometimes leading to arrhythmias and heart blocks. So you want to do your ECGs every month for as long as your patient is taking bedaquiline. So these are some of the tests that are quite important. And remember, we said as long as your patient is on treatment, they will get a smear and culture every month, right? And then the 4-month culture determines the duration and your further action and whether your patient has treatment failure or not. Now, just to see if this issue of baseline tests, you were following me, which ones might you want to do in terms of baseline tests for Vuyo? Because you said we are going to give him short regimen for now, pending confirmation of the history and other things. All right, so chest x-ray, yes. Extended phenotypic DST is not indicated. Extended phenotypic DST is not, because we only do it if he had a resistance profile to the second line. So the extended one, we only do the reflex. And then FBC, yes, linezolid ECG because of bedaquiline. I want to show you indications for the TSH. So if your patient is going to be receiving, let me stop the poll. If your patient is going to be receiving ethionamide or PAS there, that's when you'll be doing your TSH. When you say short regimen, it does not include ethionamide or even PAS, right? We use terazidone. So there's no need for us to do a thyroid stimulating hormone, and there's no need for us to do an extended phenotypic. So we don't do the extended culture. We only do it in patients who are failing a lot of our second line drugs. Then we want to see if the other drugs would work. So please remember, differentiate between your reflex test, your DRTB reflex test, where we do LPA, then the phenotypic test, versus the extended phenotypic test, which is only done after you have called the microbiologist and you say, I have a patient who's failing everything. Can we look at other drugs? And then they will then help you from that. Can you then tell me about the ARVs? When will the ARVs be started? This is probably one of the last second questions to pose to you. If he started on MDR treatment, what is the preferred time to start ARVs? Let's go. 2 more seconds. Let's go. Yes. Right. I'm going to stop right there and then show you what the thinking is. And I can tell you, with drug-resistant TB, we prefer 2 weeks, right? But it's all about whether your patient is tolerating the DRTB treatment and how quickly do they need the ARVs, because his CD4 count was 120, yes. So we could still even continue TB treatment for at least a month and start ARVs. But generally, 2 weeks is the standard time that we really want to target and initiate ARVs as soon as possible. The reason is we don't want this iris. And please attend next week's masterclass. We are going to deal with a patient who deteriorates after starting ARVs, and we'll discuss, iris further, this exaggerated inflammatory response that our patients get when you start them on ARVs before the opportunistic infection is treated effectively. So you start them on ARVs, the viral load is suppressed, there is a rapid rise in the CD4 cells. On the positive side, we are winning. We've got fewer opportunistic infections. On the negative side, you get this exaggerated inflammatory response, and we don't want it too early, right? We want to treat the opportunistic infection effectively, then start ARVs, and then monitor our patients very closely. So we'll discuss iris next week. But in terms of TB, you would see there drug-resistant TB, which is what we are discussing. It's always preferred to start ARVs within 2 weeks, especially for those who have low CD4 counts. But if you are dealing with an immune competent patient, you can treat the TB for at least a month, then start ARVs. And remember, if you start ARVs a month later, you are reducing the risk of this exaggerated inflammatory response that we would have to deal with. But sometimes our patients have very low CD4 counts, and we can't wait even for 2 weeks. So we have to start, but then monitor our patients very closely. Right. Now, based on the case history, Vuyo, CD4 count is 120, he's 45 years old. There are no other issues except that he had an INHA mutation, and we started him on a short regimen, right, for argument's sake. What ART regimen would you prefer for Vuyo? This is probably your last poll for the day. Which of these 5 ART regimens would you recommend for a 45-year-old male patient who's starting ARVs with drug-resistant TB? Very interesting. We're gonna get to the integration now, because that's where the issues start. All right. Let me show you your results, and then please do pose any questions you have. I like questions as well. Right, so most of us say TLD, tenofovir, lamivudine, dolutegravir. Some of us say efavirenz, and the rest really not that much. So let's look at what are some of the things that you should be cautious about in this patient. So this is the summary of first-line regimens in the country at this point in time. If you look at our case scenario, it's an adult patient who's more than 35 kgs, right? Therefore, TLD or with efavirenz is the regimen of choice. And I saw most of you chose either tenofovir, lamivudine with dolutegravir, or tenofovir, lamivudine with efavirenz. So let's then look further to see, which ones, And then also don't forget that in terms of our second line regimens, we also use drugs like zidovudine, and which might be an issue for patients who are taking drug-resistant TB. So a few things to pay attention to. Number one, the key problem is bedaquiline, this particular drug. It is metabolized by your CYMP or your liver enzymes that also metabolize other drugs. So it is affected by drugs that can be called liver enzyme inducers or liver enzyme inhibitors. Remember, if these enzymes are induced, that means they are activated to work faster than normal. Bedaquiline would be metabolized very quickly, so you wouldn't get good treatment outcomes, right? Because you'll get low blood levels. However, if a patient is taking bedaquiline with a drug that is known to be an inhibitor of these enzymes, you are going to get high drug levels of bedaquiline with exaggerated side effects and toxicity. So this is quite important for us to know. So if it's taken with a liver enzyme inducer, you get reduced blood levels, and therefore your patient might fail their TB treatment. If it's taken with a liver enzyme inhibitor, you've got an increased beta-quilin toxicity because the enzymes that are supposed to metabolize beta-quilin are slowed down by an inhibitor. So when you look at efavirenz, it's got a very strong interaction with beta-quilin, right? Because efavirenz induces the enzyme. So efavirenz induces the enzymes, they metabolize beta-quilin quickly. You've got low blood levels or blood concentrations of beta-quilin. Your patient is likely to fail treatment, right? So, and the exposure or the drug concentrations to beta-quilin are reduced by up to 50%. So this is quite important to note. Therefore, efavirenz is contraindicated in patients who are taking drug-resistant TB that contains beta-quilin. So that is the interaction there. Efavirenz and beta-quilin should not be prescribed together for any patient, right? So I hope you got that. It's a tick. The second piece now, right? So Situro here, we're talking about beta-quilin. We know that it is associated with some cardiac arrhythmias, with a QT, prolongation, sometimes even leading to death. So this is a side effect we know. That's why we must do your ECGs for these patients on a monthly basis as long as they're taking beta-quilin, right? But these inhibitors, co-administration of beta-quilin with any drug that slows down the metabolism of beta-quilin, it would lead to increased levels of beta-quilin with a potentially high risk for this adverse reaction, particularly your QT prolongation with heart blocks, and so on. So therefore, the use of drugs that are strong inhibitors of the liver enzymes should be avoided unless if the benefit really outweighs the risk. And we do find ourselves in that corner, but it is rare. And these are some of the drugs like ritonavir, you see now. So ritonavir, we always knew that it's a liver enzyme inhibitor. It slows down the work of these enzymes, their metabolism. Therefore, a drug like beta-quilin would accumulate in the blood to toxic levels, causing a very bad cardiac side effect, which is what we don't want. So, and you can't cram these drugs, right? You have to use your formulary. Always check your drug-drug interaction. You can see your anti. So if you have an epileptic who's got drug-resistant TB and is also HIV positive, you have to check whether these drugs can be given together. And look at how some of these patients might be having a positive crack antigen, and you are giving high dose fluconazole, 1,200 milligrams to prevent cryptococcal meningitis, whilst also giving ARVs that have a ritonavir. And in addition to that, your patient is on a regimen that has beta-quilin. It's a huge risk factor for prolonged QT elongation and leading to heart blocks and arrhythmias and heart attacks and all those kind of things. So very, very, very important that you pay attention to drug-drug interaction. Linezolid and zidovudin, both may cause bone marrow suppression. So generally, if a patient is supposed to be taking second line with zidovudin, we might want to consider another drug whilst they're taking. Remember, linezolid is only for 2 months. So maybe after 2 months, then you can be, they can be restarted on your zidovudin right there. So quite important to note, because if they take both linezolid and zidovudin, most likely they will present with anemia at some point, right? Now, here, I want to explain something, but you will read it from the slides. If you are working in the HIV space, you would know that dolutegravir is a good drug. So let's start there. Dolutegravir is a good drug. However, its effectiveness is affected by the NRTI backbone that you are using. Dolutegravir requires at least one NRTI to be active. So where you have a patient who is a defaulter, so someone who was taking tenofovir, lamivudine, and efavirenz, and they are a default. I remember they're taking tenofovir, lamivudine, and efavirenz. They are also taking drug-resistant TB drugs, which has bedaquiline. Now, we said efavirenz and bedaquiline cannot be given together. So you are restarting this patient. Traditionally, we restart patients on a regimen that they were previously on. So this one says, no, I was taking tenofovir, lamivudine, efavirenz, and you are saying, I want to give you the same regimen. But the challenge is the patient is also taking bedaquiline for the DRTB. Therefore, the efavirenz must be stopped. We want to give dolutegravir, right? We want to give TDF, lamivudine, dolutegravir, and bedaquiline. But what is the challenge when you do that? The challenge is you are removing efavirenz, you are giving dolutegravir. How sure are you that tenofovir is still active in that regimen? You are not sure. Do you follow now? You don't want to compromise dolutegravir by giving it with a weak NRTI backbone. So you would rather give dolutegravir with AZT. But there is a problem. If you give AZT, what happens? It will interact with liazoline and cause severe bone marrow suppression. So what is the best regimen for a previous defaulter on efavirenz who's also having drug-resistant TB? What is the best thing to do? Is to not give DTG, is to give lopinavir, ritonavir, lamivudine, right? And with the same tenofovir. Because remember, lopinavir, ritonavir is a very good drug. It doesn't matter which NRTI backbone you use, you can still use the drug. This thing I'm explaining, this slide is quite complex if you are not used to the HIV guidelines and when to use DTG and when to use lopinavir, ritonavir. But to summarize it for you, previous defaulters on tenofovir, emtricitabine, and efavirenz, when you restart them on ARVs, you can't start efavirenz, right? Because it will interact with bedaquiline. You can't start DTG because the NRTI backbone is probably weak because that patient is a defaulter. The best regimen to restart those patients on is a regimen that has lopinavir, ritonavir, lamivudine, and TDF. Even if TDF might be weak, lopinavir, ritonavir will handle that weakness very well because it is a very potent ART. All right, so yeah, I mean, that is the same thing, the health system issues. Yeah, all right, so I'm going to stop there. And maybe just for 5 minutes, Dr. Mudiba, are you there?
Yeah, no, I'm still here.
Yes, I want to ask you so that the colleagues can hear some of the things. Here's a case study here, a 34-year-old male who's HIV positive on TEE for 2 years, you see, ne? And is currently diagnosed with rifampicin-resistant TB through GeneXpert. He reports that he was also treated for MDR TB treatment 3 years ago with streptomycin. His chest X-ray has multiple cavitations on both lungs. That is the case, Dr. Mudiba. Can you take us through some of the things we need to be watchful of in this particular case?
All right. Thank you, Dr. Mawela. I think also you did justice to the presentation. I mean, you gave so much information about it, and then I think it was simplified. But coming back to the case, remember, in terms of when it comes to regimen for this patient, it is important to do exclusion criteria for the patient. And when it comes to DRTB, there are certain criteria that you need to fulfill for a patient to start on a regimen. Remember, there are two regimens. It's a long regimen and short regimen, like Dr. Mawela has highlighted. So proper history is important to take on the patient. And on our patients here in case 2, there's a report that the patient was treated previously with MDR-TB. Now, unfortunately, you wouldn't want to risk this patient on a short regimen because they was treated. Unlike the case you did earlier, where the patient was treated with TB, most probably it was the DS because there was no information per se. The other thing is when you are doing tests, it's important that you follow up with the results of the patients before you start treatment, because it determines the kind of regimen. Where here, in this case, there's a chest X-ray, and a chest X-ray gives you what you call multiple cavitation. So that will determine in terms of the DRTB regimen you're going to prescribe. And then also the patient is HIV positive, he's on TE. So you also have to look at in terms of, are there any drug-drug interaction on the patient? And also you have to look at the compliance of the patient, which will also help you in terms of managing the viral load of the patient.
Thank you, Dr. Muliva. So basically, this patient does not qualify for short regimen because of previously being exposed to second-line drugs, and he's got a severe TB, multiple cavities right there. Then we must pay attention to drug-drug interactions, especially between efavirenz and bedaquiline. And then if the viral load is not suppressed, we do adherence. We repeat it in 2 to 3 months. If it's still high, we probably need to switch the patient to second line. But when you switch to second line, remember second line has AZT and lanzonide. We need to avoid their concomitant use. So those are the blind spots right there. Dr. Muliva, this particular case, a 25-year-old female who is 4 months pregnant. She's HIV positive and currently, with a resistant TB bug. What are the decision points there?
Yeah, so the most important thing is to know that in terms of the drugs that you are using and its safety for the pregnant woman, there's no, unfortunately, a clear study. Unfortunately, we are not allowed to do that with pregnant women. So unfortunately, there are no studies that shows the safety of the drugs. So what is important in this case, because she's pregnant, you need to counsel the woman about the drugs, but also highlight the advantages of the treatment, because the risk here outweighs the benefits here outweighs the risk in terms of the TB drug might be the drug TB will be treated in terms of your drug resistant TB will be treated, but there's no in terms of surety in terms of what the drug might do in terms of the side effects on the baby. But what is important is the mother being treated for the DRTB. So you wouldn't want to have a situation where the mother gets killed by the DRTB and the baby survives. So, but obviously, information needs to be highlighted on the mother in terms of counseling, and then the proper advantages and disadvantages and put on the table, and then make sure that the mother makes the right choice in terms of the treatment.
Great stuff. Thank you, Dr. Muliva. And yes, the drugs, I think from regimen 1, most of those drugs, yes, they are classified as relatively toxic, but also relatively safe, because we haven't seen a lot of incidences, of teratogenic effects. However, injectables are really, the absolute contraindicated class of drugs. Luckily, in our both short and long, we tend to avoid the use of those injectables. But where we are put in a corner, we need to remember that those particular drugs should not be used in pregnancy. And then as we treat the TB, let's remember the HIV side, that at the end of the day, we want the baby to be born, alive, without HIV and without TB. And I wish we had time, Dr. Muliva, but I think in the course, please do register for the course. We do deal with then the prophylaxis, because when the child is born, there's an issue of prophylaxis. Hopefully by the time the child is born, the mother is smear negative so that the risk of transmitting TB to the child is minimized, and hopefully the viral load is suppressed and the risk of transmitting HIV to the child is also, minimized. Dr. Mliba, picking your brain for the last time. 33-year-old male patient, HIV positive on TLD, tenofovir, lamivudine, dolutegravir, and is taking a short regimen. He's been on the short regimen for 1 month. He comes to your facility for the 1 month follow-up. Can you address firstly some of the assessments that are important? But now, bullet 2 there, it says the baseline LPA result. First line LT says INH resistant, and unfortunately, we are picking up both mutations, CAT-G and INHA mutations. So how do you approach? What is the approach to this? What you call it, to this case? Yeah, Jabulani, I'm reading your comment, so I'm laughing. We'll come back to that. Thank you.
Yeah.
Yes.
I mean, in terms of the test, what is also important is to know that when you are going to be stopping the drugs and everything, the duration, because if you know that the initially you're going to be stopping at 2 months and now it's a 1 month, you know that the assessment that you need to make, you still need to do your visual test for the patient, and then you still have to do your full blood count for the patient, and then like Dr. Mawela highlighted, ECG for this patient, it's month 1, so he's still on veracolin. So it is important to know in terms of all those drugs, you shouldn't be not doing the test that are required for that patient, then you might compromise that patient. Now, in terms of number 2, I mean, Dr. Mawela highlighted in terms of the DRTB reflex test. I usually call it a combo test. I mean, there's a lot of different tests in terms of that. So it is important to retrieve results because they are reflex tests. So the gap that we normally see is clinicians don't retrieve results because KG and INH mutation, they normally they come after 3 to 4 months the patient is on treatment. And if you don't retrieve them, we have seen patients who are all on short regimen. And the principle is if you have a patient with these 2 mutations, that patient is not at all eligible for short regimen. So the importance of retrieval of result is important, or else you're going to leave this patient to be on a short regimen, which is not actually supposed to be his regimen, but it's supposed to be on a long regimen. And I mean, it's very important in terms of your approach for that. You need to retrieve the result. Thank you.
Yes, Dr. Mliba, thank you very much. I think, we've managed to cover a lot of ground. Jabulani says he just realized now that FDR-TB needs a diploma of its own. He wants a suggestion of how do we deal with that. Lesego seems to be happy with today's session. Colleagues, are there any questions? Anyone who wants to raise their hand? I know we are behind time, but we can still have 1 or 2 minutes just to deal with
sorry, Dr.
questions. Yes,
Dr. Mawela.
Yes.
Sorry, before questions, I'd like to appreciate and be grateful for we have the management from Mpumalanga Provincial Office on the panel, and I'm very happy that they have attended this session with us. We have TC here, Tsela, who's the director of TB in the provincial office. So yeah, we just want to appreciate their presence. Thank you.
No, that's superb. Thank you very much. We appreciate that. Colleagues, do you have any other comments? I see there's Teboho there. Teboho, you may unmute your mic. Teboho, yes, you can say, you can speak. We can't hear you. I see you have unmuted, but we can't hear you, Teboho. It's not nice. I would have liked to hear your voice. Teboho, I'm sorry, we can't hear you. Maybe try to type in your question. I'm really sorry about that. Lerato, drop us an email for the APC guideline. Jabulani, how long does the LEM test stay positive? I don't have the actual duration, but I know that it stays positive for a while. So even the LEM test is not supposed to be used for monitoring treatment. The LEM test is meant just for diagnosis, and then you monitor either with clinical indicators like your weight, your BMI, you know, the symptoms, and then if you did get a positive smear, then you can then use your smear as well. If you had a very bad X-ray, you expect some improvements after that. So that's quite important. TC, I don't know, I'm putting you on spot. Is there anything you want to add from a government side in terms of the program and how it's doing?
Colleagues, good evening, and thank you very much for the opportunity. I think the only thing I can say is that I think this session is very appreciated. Dr. would note that as we are decentralizing, we really need more of our colleagues to be capacitated to be able to manage the RTB. So this is very appreciated, and I think it will go on like this. Thank you very much, Devas, for the acknowledgement.
Thank you. Try to do the diploma, the RTB in an hour, a bit of a difficult task, but I think we've managed to open your eyes. Those who are going to write the diploma, I saw a number of questions about the RTB, the diploma question papers. So we will share the slides, share the recordings, and then you know our emails. You can write and ask us questions, and we'll be able to help.